Good morning, everyone, and welcome to CAHN's Health Hour. This morning, we are delighted to have, our own local GP, Dr. Joseph Omofuma, with us, and he's going to be sharing with us about what he's seen on the front line, take questions, general questions, for GPs. But also, Dr. Joseph will be talking, a bit about mental health and some prevention messaging. So I'm going to hand over to Dr. Joseph. Thank you for making time at short notice.
Thank you, Pastor Charles, for the opportunity. Good morning, everybody. I hope we can all hear me okay. Like Charles said, my name is Osage Joseph Omofuma. I am originally Nigerian by origin. I became a doctor about 20 years ago. I have a background in emergency medicine and became a GP about 80 years ago. I practice in Rochdale, where I am on the health board representing children and families. I also have a special interest in mental health as well as family and reproductive health. So today, I stepped in to just to give us a brief, because mental health is it's a big issue, but more so in the Afro-Caribbean community, where unfortunately there's a lot of stigma and misunderstanding around this. I must say also as a disclaimer that I'm a person of faith. I pastor a local church. I also do motivational speaking. So I'm going to be putting all that into the context of my speaking to us today. But purely today, let's talk about the medical aspects of it, as it were. So mental health is something that's generally poorly understood. And unfortunately, most of us who are Afro-Caribbean, when we don't understand something, we assign some kind of spiritual connotation to it. In terms of the world events and what's going on now, we know that there's an ongoing global pandemic, and I have been very privileged to be a part of those who are helping out at the front line. But also just to say that there are still a lot of things going on, especially in Greater Manchester. We are not out of the woods yet, and I want to use this opportunity to really urge everyone who is on the program and who may be watching later on to please continue to exercise very extreme caution. We are still seeing the number of cases rise up. We are still seeing people get very ill. The fortunate thing about COVID-19 is only about 10% of the actual cases become severely ill to the point of needing hospital and dying, etc. But you don't want to be part of that, and you don't want to be the person who is spreading it to other people to make them to feel ill. We've had to change the way we practice at the moment. So you may have noticed that your GPs are doing more telephone and video consultations and also doing a lot of remote working. This is also for your protection, because a lot of health workers we get exposed to a lot of illness a lot. And so if you're a vulnerable person, for example, so if you're over 50, over 40, you have an underlying health condition, you have diabetes, asthma, you really don't want to be coming anywhere near a GP practice, because you're more likely to be exposed to illness and more likely to get poorly from it. So in terms of what's happening in the front line, the fight is pretty much still on. We are actually bracing now for the flu period, the flu season, which is from autumn, from September down to December. A lot of my colleagues are worried that the system may well be overrun, but we are taking all the necessary precautions to try to make sure that we look after the populace. And really, we need the cooperation of people to continue to take precautions by social distancing, hand washing, and making sure that you wear facial covering. It's really, really important. All the research has shown that every country that has followed these simple guidelines has seen a massive reduction in the number of cases of COVID and even related influenza viruses that we see. Let me just say this as well, that right now it's all about COVID, but there are other things that are still unfortunately quite deadly. So if you have, for example, a severe health condition like diabetes, asthma, if you suffer with any form of chronic illness, please go and see your GP, because unfortunately the flip side of this is that we are seeing a lot of delays in cancer diagnosis. We are seeing children not being properly immunized. We are seeing people delaying coming to GP because they are worried about COVID-19. No, there are still other things that are happening to people. So please, if you feel unwell, your GPs, your practices, and your advanced nurse practitioners will be they're still very much placed to be able to attend to you. I see a lot of people only now. I see them via video, or I do a telephone consultation, and we're still able to make diagnosis. People send pictures in of spots, but I think you get the idea. So please, let's still be aware. Let's keep on still being cautious. I want to try and be quite um, succinct with my time today. So like I alluded to at the beginning, I want to give an overview of mental health, but in particular, I want to focus today on anxiety and depression because this is by far the most common presentation of what we see. Like I said, I became the mental health lead for my local practice almost by default because I have a special interest in it. And right from medical school, I've always had an interest in mental health because it intrigues me how sometimes a lot of these mental health situations are often neglected. You know, if you see somebody who is bleeding, you know they're unwell. You know that there's something wrong with them. If somebody has diabetes, you know that there's something wrong with them. But mental health is one of those very subtle areas where you can't really see anything physically going on. And so there is the assumption that, maybe the person is just weak, or maybe the person is making it up. That is not the case. I want to start by saying mental health is a very valid illness on its own. And unfortunately, I don't know what people's backgrounds are. I'm Nigerian. In my culture, there's no such thing as mental health. You're not supposed to have mental health. They tell you to get on with it. They tell you to move on. But as more and more education comes on board, we realize that it is quite real. It happens, and it's a lot more common than we actually know. So part of what I'm going to be doing today is giving us pointers for us to identify it either in ourselves or in our loved ones or people around us. But let's just give a broad overview, shall we? So first and foremost, there are different types of mental health conditions, ranging from very extreme conditions like in psychosis, such as schizophrenia or schizoaffective disorders. Schizophrenia simply means, schizo means to split, and phrenia means personality. So split personality or different, it's a very extreme form of mental health. And sometimes when we think about mental health, that's the picture that we often get, the madman running on the street with no clothes. But it's a lot more than that. That's one extreme. The other side of it is something as mild as personality disorders. You have borderline personality disorders, you have obsessive compulsive disorders. So there are loads of different things that are just there that are not, you don't see it, they don't need hospitalization, they don't need treatment. Some of them are not even on medication, but they're still a form of mental health. In between, you find things like anxiety, depression, which I really want to hone on today. Let's start by defining things. Depression is classified as sustained low mood, sustained low mood. Notice that I said it's sustained. And usually the period that we work on is about 3 to 4 weeks. It has to be sustained. Humorously, let me say that if Man United lose a match, I may be low in mood for a few minutes, but that's not depression, because I hear people banding around this word saying, oh, I'm depressed, I'm depressed. Somebody hit my car, I'm depressed. Somebody ate my food, I'm depressed. That's not depression. That's not real, that's not clinical depression. You can have depression from simple things, sibling quarrels and things like that. No, but clinical depression is sustained low mood. Usually, that's why we don't make the diagnosis until you've got symptoms for about 3 or 4 weeks. There are other types of depression that you can get, like postnatal depression, which happens after a woman has given birth. There are 2 categories of that where you have maternity blues and maternity blues, which is short-lived, usually happens immediately after childbirth. But after 4 weeks, if the symptoms are carrying on, then it becomes postnatal depression. What are the signs and symptoms? This is where I really want to, I feel that as a people, we need to be able to recognize it a little bit more, especially those of us who are of faith. The Christian faith We want to believe God for everything. We want to take everything to church, and that's okay. But all the research that has been suggested, the research that was done in America by a Christian doctor, who said for every 2 people that go to a pastor, at least 5 people have been to their doctor for the same problem. So as a community, it's really important for us to be able to look out for one another and be able to recognize these things and be able to help each other, because sometimes that's all people need. So what are the things to look out for? There is usually a sense of hopelessness, a sense of hopelessness, like tomorrow is not going to bring anything good. There's a lack of interest in things that people normally enjoy. People lose interest in the things that they like doing. And those are telltale signs that this person may be depressed. There's also withdrawal or seclusion. The person just wants to keep to themselves. If you have a friend who used to be bubbly and bright, and then all of a sudden now they don't want to go out, they don't want to do anything, you need to start watching out for them, especially if they've suffered a life event. And I'll be coming to that when I talk about risk factors. Not wanting to participate in activities, not wanting to go out, low mood, being tearful for no reason, a lack of interest in things, and a general sense of hopelessness, not being able to see anything good in the future. Those are the key signs of depression. And usually, unfortunately, depression plays a part in most of the mental health. Depression plays a part in schizophrenia, for example. Depression plays a part in dementia. So this is why I'm sort of honing in on this, so that we can use it as a template to identify other things. Because even in terms of risk factors for other illnesses, you will see that depression plays a part there as well. What is anxiety? Anxiety is an unrealistic fear that something bad is going to happen. There's no basis for it. I mean, if you've been robbed once and you're anxious that somebody might break in again, then there's a basis for that. But if you have absolutely no reason whatsoever, there's a sense of foreboding, there's a sense of feeling that something bad is going to happen. That's anxiety. See, all of us get anxious from time to time. Everybody, that's the thing I should mention about mental health. All the signs and symptoms of mental health have a period of normality. In other words, normal people will experience exactly the same thing. Now, the problem arises when these symptoms become sustained, when it starts going on and on and on. If you're anxious for a few minutes, that's fine. If you're upset about an interview, that's okay. But when it carries on and on and on, you and I should begin to think, hang on a minute, maybe this is something related to mental health. What are the risk factors for mental health? So we know that the family history, if someone has suffered from mental health in the family before, then there are other people are more likely to suffer from mental health. If somebody has been diagnosed with a mental illness, they are more likely to suffer from it. The female sex are 2 or 3 times more likely, unfortunately, to suffer with mental health. And I'll put a caveat on that. While females are more likely to suffer with mental health is often more severe in males. And I'll give you the prognostic criteria. Also, your personality type can predispose you to mental health. People who are anxious, have an anxious personality, people who tend to worry, that can predispose you to an anxiety disorder, or even going on to depression. Stress. So an adequate work-life balance is very, very important. Stress plays a key factor, especially in this part of the world. Stress is really, really important. Stress is so important. Life events. But what do I mean by stress? You work long hours. You work 12 hours in the day. You're not sleeping. You're not doing anything to relax or to unwind. It builds up over time. And before you know what's happening, other things begin to set in if you're not careful. Life events, a woman who has just lost a baby, or a bereavement. You've lost a father, a husband, a wife. Life events can tip people over to suffering with mental health or depression. Social isolation, this is a massive one. This is big. Social isolation is one of the key things that tends to, is one of the bad prognostic factors for mental health. Low socioeconomic status or low education, people who are deprived, Generally, if you're worrying about where am I going to get food, where am I going to get this, and all of that, you're more likely to suffer with mental health. Also, the elderly, over 65s, are more likely to suffer with mental health. Um, Also, chronic illnesses like Parkinson's, diabetes can predispose you. Now, I talked about prognostic factors, things that you can say if somebody has this, they're more likely to suffer with a bad bout of mental health. So, number one prognostic factor is family history. If there's a family history of mental health, then that person is more likely to suffer with a bad episode of mental health. The other thing is the male sex. Like I said, females get it more, but it's often more severe in men, in males. And also people who are single. If you're married, you have a better chance of recovering better or getting better from it. But people who are single or people who are not in a relationship tend to have a worse prognostic factor. So it comes down again to what I was saying about isolation, social isolation. Social isolation is one of those things that really makes mental health to be worse on all levels. Human beings were not created to be isolated creatures. We're created to be social creatures. We're created to relate with people. And so when you begin to isolate yourself, it does something to you. It begins to get to you. That's not the way we were wired to be. Another bad prognostic factor is not having a job or employment. It borders on people's psyche a lot. So if you're unemployed, if you're male, if you're isolated, if you have a family history, that generally predisposes you to a more severe illness. Also, a history of um, recreational drugs, such as cannabis, cocaine, heroin, etc. That again is another bad prognostic factor. So how do we've talked about how to identify it, we've talked about what it is, we've talked about the risk factors, we've talked about who is more likely to suffer from it, a few scenarios here and there. Also, let's look at what treatments are available. Now, when I talk about treatments, I'm going to be talking about both medical and non-medical treatments. And interestingly, one of the things that I find that often helps people is if you begin to associate more with people, just associating more with people or doing something with other people. So very often I tell my patients to go and volunteer in an elderly home, or I had a particular lady who she started looking after injured horses and her depression went away. Another lady, I referred her to go and learn flower arrangement. And eventually she gets a job there. But then after a period of time, she comes off medication. So associating with people and sort of getting rid of that social isolation is a major treatment modality. Also, exercise and lifestyle, of course. If healthy body becomes a healthy mind, you have to be exercising. You have to be doing something. Interestingly, one of the things that helps, apart from the fact that exercise on its own is quite helpful, but most of the time when we exercise, we're actually doing it with other people. You're running in the park, you're going to the gym, inevitably you're running into people. So all those things help us to become more mentally balanced. Now, of course, there is medication, and there's a whole group of lots of different groups of medication of antidepressants, the SSRIs, that you know of, and I tend to I'm quite happy to prescribe that to people because I see that it works. As a matter of fact, the recent research suggests that not very recent, the last 10 years suggests that it's a combination of medication and therapy, which is another thing I should mention. Talking therapy, such as CBT, DBT, etc., which is obviously different to counseling. Counseling is also good, but talking therapies like DBT, CBT are absolutely important. And the research suggests that it's a combination of medication and talking therapies in addition to lifestyle changes that yields the best results. What I often find is that most people pick and choose. They say, well, I just want medication. I don't want to talk to people about my problems. Or they say, well, I don't want medication. Then I just want to talk to somebody and all the rest of them. Or they say, well, I'll use my lifestyle. You see, I often tell people that it's a combination of all these things that we have seen that gets the best results. And some people may have an issue with medication. I'm quite happy to take questions on that, but there are lots of different medications. Most of them are perfectly safe. One of my case in point is a lady who She's a CEO. She retired recently as a CEO of a very prominent organization. She's a Caucasian lady. She took antidepressants for 22 years. And after like 22 years, she came to me and said, can I stop taking my medication? I think she must have been 58 or 59. And I simply said to her quite humorously, because by this time I'd gotten to know her well, I said, well, if it ain't broke, don't fix it. You've taken this medication for 22 years, you've been fine with it. She was able to go on. The point I'm making is not that medication is necessarily advised or my first line of treatment, but she was able to live a successful career. As a matter of fact, she excelled in her industry, even though she had a severe mental health problem. She suffered with severe anxiety and depression. It ran in her mom, it was all her aunts, but she lived a very successful career. She had a good marriage, she brought up good children, but she was able to do it with a lot of help. Because one of the problems we find with the Afro-Caribbean community is because of this whole stigma and things associated with mental health, people hide and they don't bring out their issues, and it compounds and it becomes worse and worse and worse. Like I said at the beginning, mental health is no different to having diabetes or asthma, in my opinion, or any other chronic illness. And even from a spiritual point of view, most of the mental health cases that I see have nothing to do with being with the spiritual. If you dig into it very carefully, you'll find out that a lot of those issues are, psychological issues that that we can deal with. So these are some of the things that I wanted to highlight to us by way of a general broad overview. I was given 25 minutes to speak. I think I've only used 20. So I'm quite happy to take questions that may be pertinent to some of the things you said. I know we've honed in on depression, but I'm quite happy to answer questions on mental health in general, that may be related to you or members of your family. Thank you.
Thanks a lot, Dr. Joseph. That was really informative. Well, could you comment on why, it's been said that, that there will be many more mental health issues as we emerge out of the pandemic? And then I'll move to lots of questions in the chat box.
Well, see, Charles, that is a very loaded question. So I was, interestingly, just last week, I was approached by ITV to talk about the impact of COVID on the NHS. And one of the things that it has been rightly noted by myself and my colleagues is there are many things that will impact the NHS. So the COVID crisis itself is one thing, but there are many offshoots. Mental health will increase because people are going to suffer with more financial stress. People are obviously being isolated. Like I mentioned in my presentation, isolation is a big one. It's a big issue with regards to mental health. So because of the COVID pandemic, people are more isolated. People are more likely to lose their jobs. There's less socioeconomic opportunities. And so what we're going to find is that, unfortunately, either people who already suffer with mental health or people who haven't suffered with mental health will now develop mental health simply as a complication of having been isolated, etc.
Great, thank you very much, Doc. What about eating? So I'm going to the questions in the chat box now.
Okay.
What about eating changes or habits change? You start finding empty packets of food like crepes, chocolates under the bed, tucked behind wardrobes or hidden at the back of the bed. Is this a sign of something going on?
It could be. It could be. So there are eating disorders which are also signs of mental health. You have bulimia, you have anorexia nervosa. So you need to be finding out from the person whether why are they having to hide to eat? Is there some kind of, you see, you have to look at the whole picture. Is it that there's an abuse situation in the house, or is it there's some sort of deprivation mentality? I remember when I got out of medical school, I felt like eating 10 hamburgers because we had been so stressed with not eating very properly in school. So you have to explore that very carefully. Yeah, and I think it definitely could be. It's something that's definitely worth exploring because anorexia or bulimia are two different extremes of eating disorder. One involves binge eating, the other one involves starvation. That needs to be explored and to find out why such a person is hiding food, etc.
Thanks, Doc. A young person staying in their room, not wanting to talk to any member of the family, overeating, gaining weight, very low mood. How do you tackle this change, and what do we do?
Right. So almost on a daily basis, I see patients like this, very worried parents who come in, especially teenagers. One thing we need to realize, I think I'll use the opportunity to say this, that teenagers are a very special breed of people, not necessarily only teenagers, but anybody who's going through transition. So, but especially teenagers. Teenagers are no longer children, but they're not quite adults yet. So most people who are going through transition, either they're transiting from not being married to married, or not having children to children, or they've lost someone, they're more susceptible to mental health. And so someone who's locking themselves in and not eating, the first thing you want to do is to explore what exactly is going on. Why are you doing this? The next thing you need to do is to try and get help. Try and get them to see their local GP or to speak to a counselor. That would be my first advice to you. A professional will be able to tease out the information that is required. There are certain specific types of information that is needed to be able to ascertain what's going on. I'll give you a case study because I know you wanted me to talk about case study. I was doing some work in the infirmary, Rochdale Infirmary, and this mother brings her young daughter in. I think she must have been 14 or 15. Apparently, to cut a long story short, this young lady would not speak to anyone, but I began to speak to her. And I told her, and I have a thing with young people, for some reason, I connect quite easily with them. And I began to speak to her, and it turns out that she was suffering with a lot of depressive symptoms, but it was simply because of a boy. She had this boy she really liked, and the boy was not returning the affection. And so we spent a lot of time talking about relationships and all of that. And I referred her to a relationship counselor. And now she's much better. But you see, the mom was extremely worried because she was cutting herself, self-harming, taking overdoses. It's important to get to a health professional as soon as possible. The more these things are left, the more it's more likely to become serious. And that's the message I'm sending across to people today.
Thanks, Doc. A question via YouTube. What do you mean when you talk about family history? What makes that transferable? And, yeah.
Very good. So what I mean by family history is either a first or second degree relative who has suffered from mental health. So especially first degree relative. First degree relative, your mother, your father, your brother, your sister. If any of them have suffered with mental health, then you're more likely to suffer with mental health. That's the research and the statistics. Now, in other words, there's no genetic thing. For example, we can say with sickle cell, there's a genetic component. We can say with there are lots of genetic issues where you can say that this gene predisposes you. You can't say that. But what I will say is that what we've noticed is that anxious parents produce anxious children. And so where there's a family history of mental health, so depressed parents produce depressed parents, children as well. We can transfer our own emotions and things onto our siblings, onto our children, etc. So where there's a family history, which the mechanism is not fully known, you're more prone to it. It doesn't mean they're definitely going to get it, but it becomes more likely.
Thanks, Doc. Right.
I can see a lot of questions.
So problem, why do some people have problem with taking medication? And could it be that the side effects are what puts people off?
Well, to be honest with you, Charles, if I knew the answer to that question, I would be a billionaire. Probably wouldn't be talking to you. You have to make appointments with my secretary. No, I'm serious. Let me be serious. Why do people not take medication? A lot of people don't take medication because of hearsay and because of misconceptions. And it's not just in the Afro-Caribbean community. Okay, I'll tell you, my favorite one is somebody at the pub told me that it was addictive. They're not. Why would a health professional give you something that would be addictive? Somebody told me that the sister told her, who is not a health professional, that once you take it, you have to be on it for life. That's not true. So a lot of misconceptions come into the issue when it comes to medication. Obviously, there are some medication that give side effects. All medication can give side effects. Paracetamol, ibuprofen, all of them can give you side effects. It's about finding the right one for you. So most of the time, the reason why people don't take medication is because of the wrong idea of medication. Or even the spiritual or the Christian person who says that, well, I don't believe in taking medication. I don't see anywhere in the Bible where it says, or in the Quran for that matter, where it says you shouldn't take medication. It's about the miseducation and wrong misconception.
Thanks for that. Someone is saying, I've been working with a few people who are now exercising the hormones release serotonin,
Yeah.
with mental health as well as physical health. Is the medication meant to be long-term?
So one of the classes of medication we use are what we call serotonin uptake inhibitors. Serotonin is a hormone in the brain that is produced to help you feel good. It's a feel-good hormone. And one of the things that was found in neuro in neuroscience, in the neuroscientific development of this medication, is that some people who have mental health issues sometimes have a reduction or a blockage. So what you want to do is to give a serotonin uptake inhibitor to allow for more serotonin in the person's brain, and so that they can feel happy and have more serotonin to themselves and be able to function. So is it meant to be long-term? No, it's everyone is different. What I often say to people is that treatment, just like the medication and the side effects, are idiosyncratic. It often depends on every individual. Everybody is different. I often treat people for between 3 months to 2 years. That is often my target. Obviously, like I mentioned, there are some people who who need longer periods of treatment. But I have had people who have had treatment for 3 months and they have become better. Because often when I advise people, I don't just give them medication. We often combine that with cognitive behavior therapy or other forms of therapy. I often give lifestyle advice, and then they come and see me on a regular basis. So I often commit a 12-week intensive period where we try to see people and try to get to the bottom of things. Because sometimes it's something that even the patient himself or herself has not thought about. Childhood abuse or a bereavement that they haven't gotten over, loss of a job, bullying at a workplace where they feel aggrieved, so aggrieved. So by the time you're speaking to a health professional, like I said, we are able to very often tease out these underlying things, because sometimes part of what causes it is a suppressed emotion. So medication being long-term is very much tailor-made to suit individuals and not necessarily a one-size-fits-all.
Thanks for that, Doc. Why are Black people disproportionately affected by mental health problems, in your opinion? Is it true that we have higher levels of schizo, or is it because Western doctors do not understand our behaviors?
I haven't come across any research that suggests that Black people are more susceptible to schizoaffective disorders. If anything, that is actually the opposite. Because Black people don't present to their doctors. They don't go to the doctors, and we hide it, we keep it within the community. So I haven't come across any research at all that suggests that. What I do know is that when it does happen, it's often more severe in males in Black and ethnic minority. We don't know why that happens. Maybe because we've left it for a long time. Maybe because things have been suppressed for so long that by the time it now gets seen. But in my experience dealing with mental health, as a matter of fact, it's more likely to be common in Caucasians than in Black people. Black people have a lower rate of people who suffer with mental health compared to our Caucasian colleagues.
Thanks, Doc. We'll come back to why, is it a case that we're disproportionately represented within the system? But another question, I have the experience of Black men exhibiting irritability, anger, risk-taking, substance misuse that are actually down to anxiety and depression. What are the non-classic things we might notice in our cultures?
Can you repeat the question?
So I've had experience of Black men exhibiting irritability, anger, risk-taking, substance misuse that are actually down to anxiety and depression.
Yeah.
So she's asking, what are the non-classic things we might notice in our cultures? So talking about, the Black cultures.
Well, this is a big, big, big issue. And I've seen this firsthand as well. So, like I said, unfortunately, in our community, we are not very good at talking about our emotions. We haven't had a history of being communicative. Most Black men, especially men, and even women, we express our you know, we express our we express disagreement with either physical or verbal violence. We shout, we are irritable, we talk, and that's partly because we haven't trained ourselves enough to be expressive. I don't think that Black people are generally, this picture of the Black angry woman. I don't think that's the case necessarily. I just think that you haven't been trained or you haven't learned how to express yourself. Because if you learn how to talk, I'll tell you something, a secret. When I came to this country, I had to learn how to put my emotions in check and how to pass my points across in very, very clear manner without necessarily raising you can be angry and you don't raise your voice. You can express discontent without shouting or running around or breaking furniture. And so I don't think we've learned that enough. So the thing to look out for is that unfortunately, you do get a lot more. And I think it's a cultural thing as well, where we as Afro-Caribbeans, we are louder, we shout more, we talk more, we are more aggressive in our attitude. The story I like to give is about two Nigerian men who were greeting each other and they were shouting at the top of their voices. And the nurse came out and said, "Is everything okay? Do I need to call the police?" And the two doctors laughed because they were simply saying hello. But they were so loud that this woman became afraid and thought there was a quarrel. So again, our mannerisms are different. The way we express things are different. But like the lady rightly pointed out, or whoever is asking the question, I suspect it might be a lady, we mask things a lot in our community. We hide things a lot. We suppress things. And so when we then express ourselves, it explodes in irritability, in anger, in things like that. The way to deal with that really is to begin to, first of all, education, begin to teach yourself or begin to teach our young Black men that it's not who shouts the loudest that gets the most attention. And you don't have to shout, to get people's attention. You don't have to make noise or be aggressive or even resort to physical violence. The other thing as well is behavioral, where people are more prone to getting angry. Some of us have a more angry personality, and it's all about getting help sooner rather than later. In terms of drugs and things, look, unfortunately, the whole Black conundrum is a big, big issue, starting from socioeconomic problems, educational deprivation, where I happen to work with a charity that deals with single women or single moms and their teenagers. And what you find is that these young men are angry. They're angry for a lot of reasons. They're angry because they are always excluded from school. They're angry because the father is not present. They're angry because the mom doesn't understand them. They're angry because they're just angry. and so one of the things we try to do with them is to begin to help redirect that anger to something else, to something more profitable, get them to play sports, get them to do projects, get them to do things. But it takes, there's an African proverb that it takes a whole village to bring up a child. This is coming back to the isolation issue again, where I believe that if a lot more people in our community are engaging in one way or the other, like a lot of you are, like what CAHN is doing, brilliant job, I believe that there'll be a lot less incidents of drugs, alcohol and things like that. But unfortunately, we haven't perfected the art yet. There's a lot more work that needs to be done to get our kids off the street, get our kids away from drugs. Because a lot of young people, a lot of men have a lot of testosterone to burn. We have a lot of energy, a lot of things to do. And that energy needs to be redirected in the right way. I don't think I can do justice to that question because it's a massive myriad, Hydra related question. There's loads of different things that, and somebody is asking, is it anger or helplessness? I don't see the reason why they should be helpless. I don't subscribe to that because it's all about perspective. Everything changes with the right perspective. It depends on how you look at things because the bottle is either half empty or half full. I'll give you a true life story. Two black men, they were both 31 years old by the time they were interviewed, somewhere in London, okay? I don't want to give it away, but somewhere in London. One of them had been in and out of jail and was very well known to the criminal justice system. They were twin boys, in and out of the criminal justice system. The other one was a successful lawyer. He had a nice house in a good part of town. He had 2 kids, stable relationship, everything going well for him. When they asked the gentleman who was in and out of jail, why do you think your life has turned out like this? And he simply said, because my father was an alcoholic. And, and he went on and on and on about how things were not very good for him and, things like that. And that's what has led him to where he is. Now, the same, independently, they asked his twin brother, the lawyer, who was doing well, was in a top law firm, lovely family, said, why do you think your life has turned out the way it is? And he gave exactly the same answer without knowing what his brother had said. He said, because my father was an alcoholic. My father was so bad that I decided I wasn't going to live that lifestyle. And so while we know that there is discrimination, while we know that there is deprivation, especially in the Afro-Caribbean community, I don't subscribe to using that as an excuse for helplessness. When I came into the country, I struggled for years, well, months and months to get a job. I was unemployed for over a year. Not that I didn't have the qualification, until I ran into a chap, an older gentleman who said, son, when I came in, I had to be 5 times more qualified than my colleagues in order to even get a job interview. So I made up my mind that I was going to be 5 times, not just 5 times, 6 times, 7 times more qualified than all the job interviews. So I began to pay for courses with my own money, sometimes money I didn't have. I began to do things, I began to struggle. And I began to get those interviews. And I began to walk in those corridors. Today, I don't want to say much about my personal life because it is my personal life and it's not, it's not for me to boast, but I'm involved in projects where we're helping people who are just coming into the country, especially medics and nurses, to settle down in this country and to be able to appreciate what it means to be able to settle down. Because if you come in with the wrong perception, or if you talk to the wrong people, you'll get the wrong idea. Yes, we have to struggle, but when you struggle, you're struggling in the right direction and you're doing the right thing. And so the issue should not be helplessness. Anger does not solve any problem. I often say to people is either you become bitter or you become better. I made a decision to become better rather than bitter. Bitterness does not help anybody. If you become bitter, you'll develop ulcers, you'll develop high blood pressure. I don't know about you, but I choose the other way.
Thanks a lot, Doc, and for sharing your own personal experience. If someone is in crisis in Greater Manchester, so that's mental health, what is the protocol to get help? Which services do you recommend they get help from someone of, an adult's working age? The first.
Brilliant. So that's a very good question. I like that. I was going to talk about that, I forgot. Every accident and emergency or urgent care center, they have a crisis team that are 24/7 in that department to call upon. They may not necessarily be physically there, but there's a provision for that. For every A&E or urgent care center, whatever you call them, to have a crisis team on standby. So if you walk into A&E today and that person is in crisis, somebody from mental health will see you. As a matter of fact, they will see you and they'll be able to make a decision whether you require hospital admission or whether you require follow-up with the GP, etc. So that is there. There is also the Samaritans Helpline, which is it's a non-profit organization for people who are self-harming or people who want to commit suicide. So if, for example, this person is refusing to go to hospital or refusing to seek help, you can ring the Samaritans. They will be able to give help over the phone. The other thing as well is to ring 111 and get some advice. If the mountain does not want to go to Mohammed will come to the mountain. Somebody might be able to visit them in their house. There are loads of different ways in which that person can get help. So please, that is a very good question. Let's be aware of that there's help and these helplines are there. I have a list here of, I'll give it to you to share on your website, of charities and places you can go to get mental health and counseling and help. But these are not emergency places per se, but these are all places where you can get help if needed.
Thanks, Doc. Someone is putting their comment about peer pressure, bullying, and not fitting in, and how that impacts on people. And then another question, under what circumstances would someone suffering from anxiety and depression need to be sectioned?
Ooh, okay, let's talk about bullying because it's something that's close to my heart. Peer pressure bullying, unfortunately, it happens, it does happen. It happens a lot. So the key thing is, as a parent, first of all, you want to be very close to your child. You want to be observing your child and seeing if there are any telltale signs of the child withdrawing, or, if you suspect they're bullying, get in touch with their teachers, get in touch with your GP, let the situation be known so that they can begin to signpost you to where you need help. It's not an impossible situation. Unfortunately, in some cases, it may mean that you either have to withdraw that child from that school. I've had to counsel a few parents that way, where, especially in the Afro-Caribbean community, they've come to me privately, either through referrals or things, or I've seen them privately, I've seen them at work. And unfortunately, the children have had to change schools. Now that's the extreme, but if that's what it means, then, because that child is precious. So if that's what it means, that's what it means. But the other thing I want to say, the flip side to that is, all of us should make every effort to imbibe confidence in our children. Don't let them feel that you shouldn't feel different just because of the color of your skin. The color of your skin, as far as I know, does not determine how smart you are or how much you're going to achieve in this life. So there needs to be that positive reinforcement from home, from us as well, in the home and in different places in the community, to say, look, you're just as good as anybody else. Don't let anybody put you down for any reason. And so that positive reinforcement needs to be there. And, it's one of the things I teach in my course for teenagers, which, I might be able to give more information on if time permits. Sorry, what was the other question you mentioned about?
Yeah, so the other one is, under what circumstances would someone suffering from anxiety and depression need to be sectioned?
So if they were deemed to be a danger to themselves or a danger to somebody else, then the Mental Health Act would kick in. And there are different acts, Section 2, Section 3, and all the rest of them. But it's if they are deemed to be a danger to themselves. So if they're harming themselves, either by cutting, taking medication, or they're not taking medication, not eating, if they're deemed to be a danger to themselves or to somebody else, then a mental health practitioner will be called in and the appropriate section will be applied.
Thanks for that. And then there's a comment here from Sasha. So Sasha is, a genetic counselor. So she's saying there are some genetic factors to neurological conditions in families. If people are concerned, their GPs can refer them to a genetic counselor like Sasha, and she's happy to discuss that. And there's a question about whether alcohol forms part of mental health issues.
Yeah, so in terms of Sasha's comment, thank you for that comment, Sasha. There's a lot of research that's been going on. I didn't want to get into the technical details, but there's a lot of stuff going on about the genetic aspect of it. But there's nothing conclusive yet. But I believe that definitely that person or whoever they are would benefit from speaking to someone like Sasha and getting more information about the things that could potentially predispose them to mental health. Alcohol, when I mentioned recreational drugs, I was thinking alcohol is classed, in my opinion, as a drug. So it's part of it. There's actually a type of dementia that's caused by alcohol-induced dementia. So yes, excessive alcohol plays a huge, huge role, or it can do in the development of mental health.
Great. And furthermore, suppressing emotions is very devastating. Any comments? Well, she adds, look at Prince Harry not allowed to show mourning of his mother, stepped upper lip, very sad. I don't know if you have any comments on that.
Well, it's one of the things that I mentioned as a risk factor. When we unnecessarily suppress our emotions, it builds up and it festers. It builds and builds and builds. And the person is absolutely right. There are 4 main different personality types if you want to go with Sigmund Freud's classification. you know, the cholerics, the melancholics, the sanguines, and the phlegmatics. People who have a certain personality where you are suppressing your emotion, it's not helpful. Communication, communication, communication is very, very important. You know the old proverb that a problem shared is half solved. It's so important for us to seek help sooner than rather than later. It's important to talk about these things because the more you talk about it, the more you begin to see that actually it's not a bigger problem as it should be. Unfortunately, we are in a culture, and even we the Chinese, the Asians, especially I'm talking about the Koreans, we have this culture of suppressing emotions a lot. And so when we then suffer with mental health, we find out that it's far more severe than what it should be doing. So yeah, I agree. People shouldn't be suppressing their emotions. You should be talking to people as soon as possible. The key message here is, number one, mental health is not a stigma. It's an illness like any other illness. And really, that's one of the things I'm trying to pass across to people, that there's nothing wrong if someone suffers with mental health. I have people say, oh, my brother, he doesn't want to come, but he suffers with this. Please encourage them to seek help sooner rather than later. There's nothing wrong with, it's not a sign of weakness. There's nothing wrong with you per se from that point of view. So let's remove that stigma from it. It's far more common than we think. In our adult life, it's said that 1 in 3 of us will suffer with mental illness or depression at some point. So it's far more common. That's 30%. That's a lot. That's a whole lot. The other thing is to say that, anyway, I'll leave you to finish with the questions before I begin to summarize.
Okay. Black people don't trust the system, so they won't talk. How can you say that we've not learned to talk? That's patronizing. It's the system, not us.
Well, so this is the thing. This is exactly where it's not patronizing. It's what I've experienced. It's what I've seen. You know, I can listen to somebody else's experience and hear what they have to say. But when we say we don't trust the system, I get that. You know, I really do. But what is it about the system that we don't trust? Because if you go to your GP, who's meant to be an impartial person, I'm talking about the police now. You know, I'm not talking about the criminal justice system. If you go to any doctor worth their salt, you know, they will be able to treat you or speak to you impartially without giving, and it's all confidential. So I don't understand where the issue of trust comes in, because whatever you say to me is totally, totally confidential. I've mentioned a few cases here, but nobody here can have an inkling about who they are or what they are. So we are trained that way to be able to deal with situations. But what we find is within the Afro-Caribbean culture, there's a culture of suppression where we don't really speak about things. And I see it a lot. And it's not just about mental health. We don't talk about our diabetes problems. We don't talk about our hypertension problems. We are always the last. It's the same thing with the Asian cultures. They don't come. We don't come, especially the men. And this is statistically proven. So I dare say to the other person who is asking the questions, bring your data and I'll bring mine. The men do not come. We know it's statistically proven. What I'm trying to do here is not necessarily to pull anybody down or whatever, but we want to bring these things out to the fore so that people can begin to recognize what these things are so that we can get help. You know, I believe that when we get help at the right time, we can hopefully deal with these things and offer people the right treatment.
Thank you. Paula, is there anything you want to add to that?
Yeah, challenge is on.
Great.
Time and date coming.
Okay, Paula. So yeah, another comment from Rose. Do you want to unmute and ask your question or make your comment? I know this week you talked about culturally appropriate counseling, from the Mama Health and Poverty Partnership. So do you want to make your comment, Rose? Okay, so Rose is saying, I think our own communities do not create the space to show emotion. A man has to be macho and a woman have to be accepting and be the sponge for all family problems.
This is exactly one of the things.
Okay, I think Rose is on now. Rose?
Go on,
yeah,
Rose.
thank you, Charles, and thank you, thank you, Dr. Joe, for this very, very important topic. My background is I'm from Uganda, which is an African country, and one of the issues that we have before we even talk about the system is that as African people, we are raised to suppress our emotion, like you said. But our culture does not provide a space for us to share. So, for example, if it's a marriage that's not gone right, your religion says stay. So automatically, by the time anybody talks about issues about their marriage, they're out at breaking point. So we need to create those spaces for our own people and ourselves to share problems before they escalate.
Any comment?
You're absolutely right, Rose. I'm laughing because when I was growing up in my culture in Nigeria, I'm Nigerian, even to show pain was a sign of weakness. Pain. You're not allowed to show pain. That's how we were brought up, you know, talking about. So when I talk about suppression, it's there are a lot of, it's multifaceted. And I like what you said about creating the space to do that. I've been counseling with a lot of parents. Like I said, I partner with a few charities and I'm quite happy to speak. I speak to young people and all of that, where one of the things we do is to help Afro-Caribbean parents to begin to parent in a different way, create that space or that medium where our young people especially can talk. Even for spouses, create the medium where you can talk to your spouse as equals and open that channel of communication where you guys can actually talk about things. But that culture of suppression has been there for a long, long, long time. And it's different with many different cultures, but we see it a lot in the Pakistani Indian culture. I see it a lot in the Chinese culture. We're not the only ones. But seeing that we're talking about Afro-Caribbeans today, unfortunately, it is there. There's a lot of work that still needs to be done. The other thing I wanted to say, going back to the previous caller's comments about suppression and the system, one thing that I will admit to is that there isn't enough Afro-Caribbean health professionals for people to identify with. I'll never forget when I worked briefly in Hapuhe, you know, in Manchester, Moston area. I was there as a locum GP for 18 months. And what I found was all the Black people, Ugandans, Zimbabweans, South Africans, name it, even the Russians, Slovakians, Polish, they all came to me. They preferred to come to me. And I was asking why. They said, well, you actually listen to us, you get us. So part of what I'm saying, when I talk to teenagers is that, look, many more of us need to come out and take positions. Part of the issue we have is that a lot of us, those of us who are capable of taking positions, we don't want to be in the public eye. We don't want to be doing things. We don't put ourselves out there. And that is not a criticism. It's an appeal to say, look, more of us should step out. I remember when I became a governor on the board of my children's school, some of my friends were calling me that, how much are they paying you? Why are you wasting your time? I said, no, it's not a waste of time. They need a different voice on that board to be able to, and I'm a Christian, so I want to be able to put a Christian voice on that board. I'm appointed on the board, Rochdale Health Alliance. My portfolio is children and families. So you can imagine, and safeguarding. So you can imagine some of the things that come to me, especially when they are Afro-Caribbean parents. I'll never forget the case of, it's still ongoing, a young guy from Nigeria married to a white young lady, and they were painting this boy like a demon. And he has a temper. So when the social worker comes in, he begins to shout. So I called them both in. I spoke to them individually, and I spoke to him. I told him, dude, they don't understand the fact that this is how you speak. But it took someone who understood him to be able to call him aside and say that to him. And so there needs to be more representation of Afro-Caribbeans on all these things so that we can help our people and help people understand. It's just like somebody made an off comment that all the Jamaicans that she knows are always angry. And I said, no, you need to go out a little bit more. I know a lot of Jamaicans who are not angry. You know, I have some of them in my church. And she was like, she genuinely did not know. She just made an off comment that all Jamaicans she knows are angry. And so when she sees a Jamaican, this is a white lady, she begins to be afraid. And this is somebody in a highly placed position. So you can imagine that kind of person going away with that conception that all Jamaicans are angry. If I wasn't there to challenge that and to put things right, she would just go away because she was genuinely ignorant. Now, obviously there's unconscious bias, and I don't want to go into that, that's not my area, but I have experienced that and it happens. But the point I'm just making is that, like some of you have said that I've offered their services here, there needs to be more representation of the Afro-Caribbean community for us to be able to slowly make this change and, cause this paradigm shift.
Thanks, Doc. I know we've gone over time. Just a few more minutes to take the last couple.
That's okay. That's okay. That's fine.
So when a child is always forgetting things and lack of concentration, what is that?
Well, it could mean that the child has a behavioral problem. It could mean that the child is distracted. It could be a sign, poor concentration is a sign of depression and stress. So it depends on what age of the child we're talking about. If a 2-year-old is forgetting things, I'm not worried because that's appropriate. A child under the age of 5, I'm not worried. So you need to explore what's going on in that child's life. It could be a personality thing. So sometimes children are too much in a hurry. They want to do one thing and do the next thing, but then they forget that they're actually doing one thing. It could even be an early sign of ADHD. So this is what I'm saying, that, look, it needs to be explored further, and it depends on what age of child we're talking about. I know some wives who have complained about this today, about their husbands on this issue. So it depends on what age of child we're talking about.
Great. We have to continue to work to remove the stigma, and there are people with mental health problems who are CEOs, doctors, and teachers. So that's a comment from Ghani. Then, Doc, another question. There's data to show that Black, people are more likely to be treated with medication as opposed to talking therapies. Why is that the case?
Well, that's a very good question. Generally, there's a lot of data to suggest that in terms of health in general, we don't get the right treatment. This is fact. There's data to support this. In terms of maternity, in terms of, I think Faye Bruce of CAHN has done a lot of good research on this. We as a family, we've experienced this, going to the infirmary. There's a lot of research to suggest that we don't get as good a treatment as our Caucasian or even Asian colleagues. I think it's down to unconscious bias and a lack of knowledge by my colleagues. Do you know that as we speak, I think you were in the conversation when we were talking about the fact that the medical students, because I happen to be a medical student tutor, I teach medical students. Now, the medical students, when they are taught about skin conditions, they're not taught about Black skin conditions. So when they see a Black person with a skin condition, they have no idea. And so we're working to try to change all of that. So yes, there are some systemic issues there, but I think it's a lot of unconscious bias, where a lot of our Caucasian colleagues don't really know how to treat Black people. So the first thing they want to do is to just give you medication but like I said at the beginning, I like to do things based on research and evidence. And the evidence suggests that it's a combination of tablets and medication that often helps with this.
Thanks, Doc. And then there's a question of someone says, I'm concerned that if we express ourselves with, to our GPs in a dramatic way, for example, then we may be given medication. How do medics understand the behavior of Caribbean and African people?
It's a work in progress, put it that way. It's a work in progress. I mean, I just gave the example of a young man who was getting in trouble with social services just because of his mannerisms. His arms are up in the air. He was shouting at the top of his voice, but that was just him. That was just his personality. So it's a work in progress where you and I need to know, like I've been training people, that when you go outside, as it were, outside of your home, you need to learn to speak in a calm, mannered way. I mean, I'll give you an example. When I finished my MRCGP, I went to my tutor and I told her then, I want to be a tutor. She said, why? She said, because you guys were scratching me where I wasn't itching. In other words, you were teaching me stuff that I did not need. So I began to organize in my own home. This is fact. In my own home then, I've stopped doing it now because I don't have the time. And I began to have candidates coming and I was teaching them about the MRCGP. Part of the problem was, especially with our Asian and African colleagues, they didn't know how to speak. And I said to them, look, when you're talking to someone, you do not necessarily need to raise your voice. There are very few situations ever that you need to. So it's about teaching and learning, really. That's the point I'm trying to make. I know we don't have time anymore for me to go into that, but you have to unlearn certain things. And he said, when you're in Rome, you behave like Rome. When you get to Uganda or Zimbabwe, you can shout across the street and greet your in-laws and do all that. But now that you're in Britain, take time to learn. One of the things that one of my colleagues, he told me to watch the news and watch EastEnders and see how people relate. I'll never forget, just something that mattered, something that bothered on this. One of my colleagues, then one of my consultants, senior colleagues, somebody did something that really, really upset him. I mean, I've never seen him so upset. But you know what? He came into the department, he was red in the face. And you know what he said? He went to the head of the department and said, Jim, I'm not having this. I'm not having this. I don't want this to ever happen. I'm not having this. That was him expressing his anger. And I was thinking, oh my goodness, if it was me, oh, they will know about it. The whole department, in fact, the whole hospital will know that somebody is upset today, but I was learning. And so we need to learn how the culture here works, because we don't do ourselves any service by not understanding the perception. And it's really about perception. The police stops you and then you begin to shout at the top of your voice. Why? Why? Just talk to people. Learn how to talk. Learn how to be, how to be civil with people. Even when somebody upsets you, there are parameters, there are ways of going about getting redress, rather than, time will not permit. But there's a lovely lady, I don't even have her details anymore. I went on a course, yeah, I did, on a course on, what does she call it again? It wasn't elocution, but it was about manners, believe it or not, manners. I know she lives in Sheffield, because I remember taking her card there, but she organized it for several churches, and my church was one of the ones that did it. And she was talking about manners. For example, to the average white man, saying good morning is not a prerequisite. She said when she started work as a therapist, she would walk in, good morning, and people would ignore her. In fact, one person actually responded, what's so good about the morning? Whereas in the African culture, you say good morning, you greet people, right? You want to say hello. But in the typical British culture, it's not a prerequisite. So you watch what the culture says. I go into work today, because they know that I'm a good morning person, they say good morning. Some of them even come to me now and say good morning. That's fine. I have taught them my way. But there's a place I worked in, you just walk in, hello, 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 and everybody carries on. That's it. So when you're in Rome, you behave like Rome. And let's stop. I don't want this to come out the wrong way, but I don't like people playing the victim. Yes, there's racism. Yes, there's discrimination. But don't give them more fuel to do that. Instead, let's rise above it. Let's show that we can be better than that. That's the challenge, really.
Thanks a lot, Doc. I think we're going to have you back next week, so I need to speak to your wife. Right, I think Paula has a question and then two more, and then we'll round up.
We need to round up, Charles.
Yeah, and then we'll have you back next week. Paula, okay. Please unmute yourself.
Oh, hi. Just wanted to go back to the conversation about the trust that we had before, and generally about talking. I think you can see in the UK that when it comes to mental health and sectioning, the police is usually involved. Black people are over-medicated quite often than white people. There's lack of opportunities in the UK for housing, finances, education, and the system in the UK is actually designed for Black people to fail. There's some out there that believes it, some don't. That's written in research. Black people do not trust the system, because when I'm actually a psychiatric nurse and I've worked in Manchester for 30 years, and the sad thing is I've seen, and I can hold my hand up and see that the system is not made for us when it comes to mental health. And I think that's not so much our problem as Black people, It's the systemic racism that's built in the system for us to fail. So I think part of saying we need to talk, yes, I agree with that. We do need to learn to talk sometimes. And the sad thing is, I've actually observed people coming in and shouting and rare. And I've had to pull them aside and saying, just be quiet and calm down. And this is how you're going to react. Because if you continue this way, security guards will just put you outside and you won't get anything. So that's in reality. And bearing that in mind, this is why myself and a couple of people have come together to try and build a unit in Manchester, hopefully, that's going to be Black represented, treating Black people because, on the mental health issues, because I think we can actually encourage people to feel more confident in themselves and deal with medication, plan their own recovery. Because I think that's the main thing. I think in order for us to move ahead in mental health, we're going to have to need people who can understand where we're coming from and understand if you're living in a dirty, moldy house, that's what you're gonna, you can't encourage yourself out of that because you're waking up and going back to that every day. Your child is getting expelled from school, you don't know what to do, there's nobody to help you, whereas Matthew down the road is doing the same thing. And you're in this cycle. And unfortunately, we do need a system there that's going to help us. And I think that comes from us doing something for ourselves and being able to talk to people like ourselves so we can get these things out there and move on. So that's all I have to say.
Thanks for that, Paula. Yeah, I think, Doc, we need you back next week. But, you know, the final one is, you know, the talk of unconscious bias and why is that Black people won't take medication and, you know.
Yeah, I mean, there's a lot, like what I like, there's a lot of good stuff in what Paula said. I mean, I totally agree with it. The truth of the matter is, I don't know about the system being designed for Black people to fail, but I know for a fact that the system is not designed to help you in some cases, for sure. My approach and my attitude is that, yes, there's deprivation. Yes, there is a discrimination. Yes, there's racism. What do we do about that? Do we roll over on the floor and you know, give up? I don't think so. My attitude is that there should be more people like yourself, like myself, to rise up and take up positions where we can help our people, period. I think I say this to my Pakistani colleagues, I say this to my Chinese colleagues. I don't say it openly in a confrontational way, but like I said, I've been involved on the ground in helping a lot of Black health professionals who are going through difficulties, either in their workplace and all of that. You know, one of my trainers said I should have been a lawyer because I don't like seeing oppression. I'm the guy who is advocating for people for their rights, especially the ethnic minority, but I do it for all people. That's the interesting thing. They have seen now that I will defend anybody who is being oppressed for any reason, as long as I'm in a position to be able to do that. And we keep on advocating for that. I'm involved in homeless charities, one of them that has been recognized by the Lord Mayor, Andrew Burnham. So there's a lot of stuff going on. It's not, so the thing about it is that even though I'm Black and Afro-Caribbean, it's not just about me. The system does not help people who are being oppressed. That's fact. We know that. We know the fact that also, especially for Black people, we don't get the same treatment. That is fact. My way of looking at things is, now that we know that, what do we do about that? What's the solution? Yes, creating a unit and all of that is great. That's one way of doing it. My way of, one other way, I think, is for more of us to get into government, get into positions of authority, so that we can begin to change change the laws and change. You know, if they're having a conversation about, and myself and Charles have had discussions about it, if they're having a conversation about how they want to implement certain things in Greater Manchester, and there's no Black voice or Afro-Caribbean voice to say that this is just like women. You know, the research has showed that women on a board, especially a few women, will influence how the decisions are made for the better. Why? Because women have something called intuition. Men are, shoot first, ask questions later. Most of us are like that. Whereas women take a more softly approach. They can see things that men can't see. And so research has shown that if you have a woman on your team or women on your team, you're more likely to get the best, well-rounded idea. So it's a work in progress. I'm not saying here that the system is absolved of the inequalities. All I'm saying is, as Black ethnic minority people, what should be our response? We need to rise up to the challenge and say, okay, you know what? You want to suppress us? We're not going to take this line down. We're going to stand up and we're going to move on, and we're going to even exceed and excel in these things. I always say to people, and some people may not like it, but if somebody is growing up in a moldy house and they decide that I'm not going to live in this moldy house, I'm not going to allow my children to grow up in a moldy house like me, and they make every effort to do that, then it makes a huge difference. It makes a huge difference to the outcome of their children, the outcome of their aunties, and etc. But I talk for a living, so we could be here all day.
Thanks a lot, Doc. I think, yeah, it will be great to have you back next week to continue, this conversation. And
Okay.
Thanks everyone. You've broken things down. Sometimes when people say mental health, it looks elusive and a bit vague, but you've broken things down. You've given us lots of case studies that has brought home the subject. So we're really grateful, and we look forward to having you back next week. Any final words?
Well, thank you for the opportunity, and thank you for the work that you're doing in CAHN. You guys are doing a fantastic job. Faye, Pastor Charles, all of you in the team, fantastic job. Please consider me a part of CAHN if you like, some kind of extra part, whatever you need us to do to help to move this work forward. I think CAHN is really important at this point in time for us to have these conversations and to put this word out there.
Thank you very much, Doc. One of the things that most of the professionals who come on offer sometimes is private consultation. So I've had 1 or 2 requests, and I'll be putting people in touch with you. It's just to help people articulate and navigate the system. So thanks very much. We look forward to having you next week.
Okay then. God bless. Thank you.
All right. Okay. Thanks, everyone. Enjoy the rest of your weekend, and we will continue this subject next week.
Thank you, Pastor Charles.
Thank you, Pastor Ben.
Yeah. Bye-bye.
Bye.
Thank you, Pastor Charles, and thank you everybody that has worked so hard.
Yeah, thank
This
you, Doctor.
has
Thank
been
you.
so informative, and we thank God that we have this platform. Even though COVID is doing what it thinks it can do to shut us down, we are moving forward. Thank you and God bless.
Great. Thanks, Pastor Eva.